Hello, my name is Quentin Broussard. I'm assistant professor at California Health Sciences University, and today we'll be talking about sepsis and septic shock. And the reason we're talking today about sepsis and septic shock is because sepsis and septic shock are medical emergencies that account for a majority of intensive care unit admissions. Because sepsis and septic shock have a high rate of mortality as well as morbidity associated with them, it's important to treat patients promptly to prevent any further morbidity or possible mortality from happening. As a pharmacist, it is important to recognize signs and symptoms of sepsis and septic shock to provide quick and adequate care to minimize the cause of sepsis and septic shock, as well as provide supportive care for any complications that may arise because of sepsis and septic shock. Our objectives for today will be to define what sepsis and septic shock are, to identify potential sources of sepsis. We'll also review elements of the 2012 Surviving Sepsis bundles, which are found in the 2012 Surviving Sepsis Guidelines, and determine what their future place in practice is when compared to the most recently published 2016 Surviving Sepsis Guidelines that were actually published this month in January. We will also determine appropriate antimicrobial and supportive treatment options for sepsis and septic shock. So to get started, we have a case. AF is a 72-year-old male presenting to the emergency department with altered mental status, dysuria, and hematuria over the last 24 hours. A current fever of 102 degrees Fahrenheit and hypotension with a blood pressure of 70/40. Upon initial assessment, he has a Q-SOFA score of 2 and a SOFA score of 2. AF has not received any treatment yet, and his lactate is currently pending. Which of the following is the most appropriate diagnosis for AF at this time? Is it infection, sepsis, severe sepsis, or septic shock? Following AF's case, to treat AF's underlying infection that he has, the ED physician would like to start an antibiotic. Which antibiotic should be initiated to treat AF? Is it ceftriaxone, gentamicin, meropenem, or vancomycin? The last question for AF is to attempt correction of hemodynamic instability. The ED physician would like to start fluid resuscitation for AF. Which IV fluid should be used first to resuscitate AF? Is it albumin, dextrose 5% in water, hydroxyethyl starch, or normal saline? After we talk about these different topics today, you should be able to answer each of these questions accurately and with confidence. To get started, in terms of the background of sepsis, sepsis is estimated to be a leading cause of mortality and critical illness worldwide, and is known to be one of the most common ICU presentations. Greater than 750,000 sepsis cases happen annually, and about 15 to 35% of hospitalized patients actually have sepsis. Over $20 billion, or over a little over 5% of hospital costs in 2011 were attributed to sepsis. And mortality rate for sepsis is about 1 in 4, and potentially even more. Some papers cite anywhere from 30 to 50% of patients who have a diagnosis of sepsis to have mortality. And that's pretty unfortunate given the circumstances of what we'll describe sepsis as shortly. In terms of sepsis pathophysiology, sepsis pathophysiology is very complicated. Sepsis is typically known as a syndrome, which means essentially a constellation of different symptoms. However, there is a little bit of background that happens before those symptoms actually present. Sepsis is commonly known to begin as an infection. And with any infection, an infection can progress if it's not treated. What happens once that infection progresses is that you may have some inflammation as a response that leads to some host tissue cell damage. Now, once you have any kind of tissue damage, what happens is your immune system will want to be activated. So you'll have some kind of anti-inflammatory response that will activate your immune system, such as your leukocytes. Now, those leukocytes will try to fight off the infection, but one of two things can happen at this point. Either the infection is outweighing the immune system's response, or the patient may be potentially immunosuppressed and may not be able to fight off the infection adequately. As a result of this, you lose control of your inflammatory process and you're not able to kill the underlying pathogen that's causing this to occur. Now, if you're not able to kill off the pathogen, a patient may actually start developing what we call systemic inflammatory response syndrome, or SIRS. And we'll explain what SIRS is in a little bit. But if you have components of SIRS, or systemic inflammatory response syndrome, you may eventually be able to diagnose a patient with sepsis or septic shock based off of that. Just to give you a little bit more background into the pathophysiology, as you see here, this is essentially a bacteria here. And what happens is once you have this bacteria come in and do some damage, you're going to have activation of many different systems that are going on. The one that we talked about here was neutrophil activation, as well as leukocyte activation and the immune response activation. All these things can go in together, as well as platelet aggregation and activation via some very complex mechanisms that I would not expect you to necessarily know. But essentially what I want you to get from this picture is that an infection causes all these different inflammatory processes to happen. There's some kind of damage that's done that leads to a general inflammatory response, which can lead to sepsis and eventually into septic shock. So what happens as a result of this sepsis syndrome? There are many different presentations that a patient may have whenever they present with sepsis. Now remember, sepsis has some kind of underlying infection that qualifies it to be sepsis. So as a result of that, think about things that you may see in any patient that may have an infection. You may see some altered mental status, especially if your patient's more elderly. You may see, again, the systemic inflammatory response syndrome, which we'll talk about shortly. If sepsis becomes really bad, you may see hemodynamic instability, such as hypotension, which is essentially a MAP, or a mean arterial pressure less than 65, or a systolic blood pressure less than 90, or tachycardia, which is a heart rate classified above 90 beats per minute. You also may see patients develop acute respiratory distress syndrome or acute lung injury, which actually may cause them to eventually be put on the ventilator. And what this is as a result is this lactic acidosis that you see down here. Whenever you have an anion gap metabolic acidosis, your immediate response of the body is going to be to generate a respiratory alkalosis. And whenever you have a respiratory alkalosis, you're essentially breathing off a lot more than you can probably get away with. That causes patients to be very tachypnic and not be able to get adequate oxygen and carbon dioxide exchange. That's why you may see this acute respiratory distress syndrome. You also might have acute lung injury as a result of not enough blood getting to the lungs in the first place because of hypotension. Kind of going along with the hypotension piece, hypotension actually will dictate a lot of these different things happening in sepsis. Hypotension, as a result of sepsis, can cause acute lung injury from not enough blood being essentially perfused to the kidneys. And this can cause oliguria, or a urine output of less than 0.5 mils per kilo per hour to be generated, or it actually may generate anuria, or no urine production in patients who may have previously had good functioning kidneys that could produce urine. As a result of sepsis, you may see something called disseminated intravascular coagulopathy, or DIC, which may result in thrombocytopenia. Essentially what happens whenever your immune response kicks in, you may have some platelets that respond in that immune response. And when platelets get used up as a part of your immune response, your platelet count depletes. And when your platelet count depletes, you may develop thrombocytopenia. Related to this type of phenomenon, you may also have gastrointestinal hemorrhage, or be more at risk of gastrointestinal hemorrhage. Patients also may develop acute liver injury or shock liver and from sepsis as a result of the hemodynamic instability piece. Essentially what happens is if you're not perfusing organs, such as like with the kidneys, you may actually develop failing organs such as the liver as well. Now this phenomenon does not happen as much as the kidney. The kidney is actually one of the first organs that will get hit if your patient has sepsis or septic shock. We discussed lactic acidosis a little bit, but essentially that lactic acidosis is developing as a result of anaerobic metabolism. Whenever you go down your anaerobic metabolism pathways, if you remember back to biochemistry, you generate lactate. And that lactate or lactic acid will generate an acidosis. And there are many other different things you can see with these patients too. As a result of this acidosis, you also may see patients who have hyperkalemia, other electrolyte abnormalities, and if things get very bad, you may actually see patients code, all as a result of underlying sepsis, and that can actually lead to mortality as well. Because of all this different presentation background that's happening, mortality rates are very high in sepsis patients, as we discussed earlier. It could be up to 50%. And the mortality rates are actually higher for certain patients. Patients who are older, patients who have COPD or chronic obstructive pulmonary disease, malignancy or cancer, HIV, essentially both immunosuppressed states. Also, if you have more failed organs, that can actually increase your mortality. And this little fun fact here is that mortality actually increases from about 29% to 65% when the number of failed organs in sepsis increases from 2 to 5. So the more failed organs that you have, the worse off that you may be. If you have a positive blood culture as a result of your infection or a Pseudomonas infection, you're at a higher risk of mortality, as well as patients who have intra-abdominal infections secondary to ischemic bowel. The bowel is also another area that gets hit often by sepsis because a lot of your blood flow in sepsis is essentially going to your vital organs because you become so vasodilated out. Your body tries to prioritize your most important organs, such as your brain and your heart. It doesn't worry much about your kidneys, your liver, or even your bowel. And whenever your bowel doesn't get enough blood flow, your bowel can't function. And your bowel is another big source of immune or immunomodulatory factors that can potentially prevent infection from occurring. So if you're not getting enough blood to your bowel, you may actually be more at risk of an intra-abdominal infection. And that infection can actually spread and become sepsis or septic shock. So let's actually define what sepsis is now. In 2012, they came out with the 2012 Surviving Sepsis Guidelines. And whenever they came out with these guidelines, they actually had a big table, this table 1 that you see here on the right from their guidelines, giving you some diagnostic criteria of what sepsis is. They looked at different variables that existed, such as your, what we'll call SIRS phenomenon in a second, as well as some inflammatory markers and hemodynamic variables and organ dysfunction variables. Now, because it looked at so many different variables, people essentially, kind of felt a little bit confused because there are so many factors here that it was too much to keep up with. And that is kind of a little bit of how monitoring for systemic inflammatory response syndrome, or SIRS criteria, came up. Now, what the SIRS criteria are these 4 criteria below here. SIRS criteria are essentially a temperature of greater than 38 degrees Celsius or 104 Fahrenheit, or less than 36 degrees Celsius or 96.8 Fahrenheit, a heart rate of greater than 90 beats per minute, a respiratory rate of greater than 20 breaths per minute, or a PaCO2 of less than 32 millimeters of mercury, or a white blood cell count greater than 12,000 or less than 4,000, or greater than 10% bands. Essentially, all these things are associated with an inflammatory response. Now, these things are some of the factors that are actually listed here in the diagnostic criteria for sepsis from the 2012 guidelines. Now, keeping the SIRS criteria in the back of your minds, essentially what the guidelines alluded to was diagnosing sepsis via SIRS criteria plus a diagnosed or suspected infection. Now, remember, with sepsis, you always have to have an underlying infection that causes everything to happen. So if you suspected an infection and you had potentially 2 SIRS criteria, as a lot of times was done in practice to classify sepsis, you can be classified or diagnosed as having sepsis. For example, if you have a white count of 13 and a heart rate of 100, and you had any kind of suspected infection, at that point you can consider a patient being septic via SIRS criteria, which correlate with the 2012 sepsis guidelines. Now, another classification of sepsis came with what's called severe sepsis. And severe sepsis differs from regular sepsis in that severe sepsis means that you have to have sepsis-induced hypoperfusion or a minimum of 1 organ dysfunction. What a lot of people consider to be sepsis-induced hypoperfusion is this lactate greater than or equal to 2 millimoles per liter. Minimum of 1 organ dysfunction can involve many different organs. So, for example, if you have hypotension, that's something that affects essentially the heart. So hypotension, as we covered earlier, is a systolic blood pressure less than 90 or a MAP less than 65. If you have urine output less than 0.5 mils per kilo per hour, despite more than 2 hours of adequate fluid resuscitation, you can also be considered to have organ dysfunction. Acute lung injury, or ARDS, is considered an organ dysfunction. A creatinine greater than 2 milligrams per deciliter, assuming that this creatinine is a new creatinine or an acute kidney injury related creatinine. Say, for example, if your patient already had like pre-existing ESRD and already had a baseline creatinine above 2, this would not necessarily count for severe sepsis. Same can be said for patients who have liver dysfunction or pre-existing liver dysfunction. If they have a bilirubin greater than 2 milligrams per deciliter prior to their actual diagnosis and it's pre-existing, this criteria wouldn't count. But if they have new liver injury that is unexplained otherwise, except for sepsis, then this can count. If you have a platelet count of less than 100,000, and this kind of goes back to the DIC thing I was talking about earlier, coagulopathy or an INR greater than 1.5 also goes back to DIC as well. Because in patients that have DIC, essentially what's occurring is you're clotting, and then after you clot so much and you use up all your platelets, essentially what happens is you may bleed after that. And that can result in an increased INR level. So that's essentially what severe sepsis is defined as. So it's essentially sepsis, so you have to have the 2 SIRS criteria or diagnosed or suspected infection with at least 1 organ dysfunction or sepsis-induced hypoperfusion. Now, if your sepsis is bad enough, you can actually be considered as septic shock. If you have sepsis-induced hypotension persisting despite adequate fluid resuscitation, or a lactate greater than or equal to 4 millimoles per liter. Now, we'll talk about what adequate fluid resuscitation is in a little bit, but what this essentially means at this time is a fluid resuscitation of at least 30 mils per kilo patient weight. So say if you had a patient who was 100 kilograms, and to try to combat the hypotension that the patient was having, you gave them 3 liters of fluid, or 3,000 milliliters of fluid, which for a 100 kilogram patient would be 30 mils per kilo. If they were still having hypotension at that point, you can consider them to be in septic shock. Or if they have a lactate greater than 4 millimoles per liter, you can consider them to be in septic shock as well. So it's either or for this one. Now, these definitions that we just talked about from the 2012 guidelines have been highly debated because SIRS criteria can actually fit into a variety of different categories. You may have SIRS that actually derives from infection, but in terms of what SIRS are, if you remember going back to this other slide here, a temperature that's high or low, a high heart rate, a high respiratory rate, and a low or high white blood cell count can be related to many different things. Some things that this can actually be related to are things such as patients who are post-surgery, because whenever you come out of surgery, you may actually have a high heart rate or potentially a high respiratory rate due to a stress response. Other things that can cause systemic inflammatory response syndrome are things such as pancreatitis, which produces a similar type of stress response. And those things are not necessarily infection. Now, you may have infection that's related to either a post-surgical phenomenon or pancreatitis, for example, or even trauma. Trauma is another thing that can cause a systemic inflammatory response syndrome. But if you don't have a suspected infection or a diagnosed infection, but you just have SIRS criteria, you do not have sepsis. So that was a big thing that actually led to the development of Sepsis 3. And Sepsis 3 was published back in February of 2016, last year. And again, just like the SIRS criteria, this is highly debated. But what this document essentially did was it redefined the definitions for sepsis and septic shock. Now, what they define sepsis as now is a life-threatening organ dysfunction caused by dysregulated host response to infection. Now, if you remember what the sepsis definition was from here, it just essentially was 2 SIRS criteria and a diagnosed or suspected infection. You didn't have to have organ dysfunction to be considered sepsis, but in this definition you do. It defines septic shock as a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. So that's a very, very broad definition, and from that definition you probably wouldn't necessarily understand what that exactly means at this time until we actually go a little deeper. Another important thing that Sepsis 3 brought up last year was that they actually eliminated the definition of severe sepsis, period. So now all that technically exists is sepsis and septic shock. Now, while the definitions are new, it's still important to remember our previous definitions that we had in 2012, because a lot of what happens in practice currently is what goes off of these definitions, because these definitions from Sepsis 3, as we just read here, are still being enacted currently. So you may see physicians or different practitioners actually still practice with the 2012 sepsis definitions. But there's currently a move to enacting the Sepsis 3 definitions. So if you get asked, for example, on an exam or an IRAT or something along those lines, what I will have is just definitions emphasizing Sepsis 3. But you'll still need to know what the 2012 sepsis definitions are, because those can actually help you in identifying an infection as well. And that's actually something that the Sepsis 3 authors had mentioned if you read this document, that SIRS is not necessarily, a bad thing. You can still use it to identify infection, but you just have to be careful whenever you do use it, because you can potentially not have an infection while looking at SIRS. So what does a Sepsis 3 identification actually mean, and how do you go about diagnosing sepsis and septic shock with Sepsis 3? So now what happens, and if you follow this figure here that is in the Sepsis 3 document, which is also posted on CAMS, if you suspect an infection, what you do is you calculate what's called a Q-SOFA score, or a quick SOFA score. SOFA stands for Sequential Organ Functional Assessment. Essentially what you're doing is you're looking at a bunch of different factors that can be related to organ function. So with Q-SOFA, they look at 3 different variables, and these 3 variables will be very important for you to know. Those are respiratory rate, mental status, and systolic blood pressure. So if you have any 2 out of these 3, a respiratory rate greater than or equal to 22 breaths per minute, altered mental status, or a systolic blood pressure less than 100, if you have 2 out of those 3, you move on to the next step, which is to assess for evidence of organ dysfunction using what is called a SOFA score. Moving to the next slide, the SOFA score actually has multiple factors that are associated with it, and you can have anywhere from a score of 0 to 4 on the SOFA score. The SOFA score measures your different organ systems such as respiration, coagulation, liver disease, cardiovascular disease, your central nervous system, as well as your renal system. Now, if you have a total score, once you rank each of these, of at least 2 total of all 5 of these. So basically, say if you have, a platelet count of less than 150 and a creatinine of 1.2 to 1.9, you automatically have a score of 2 total. And whenever you have that 2 total from this indication here, that indicates that you actually have sepsis at this point. Now, this is a pretty big table, and I would never expect you to memorize this. If it were on an exam, for example, I would give you the SOFA score outright. So the main thing to know from this is that if you have a SOFA score of at least 2, that indicates at minimum that you have sepsis, assuming that you've met your Q-SOFA and your suspected infection criteria. Now, going one step further, once you've already met adequate fluid resuscitation and you need an agent such as a vasopressor required to maintain an adequate mean arterial pressure of at least 65, and you have a serum lactate level of at least 2 millimoles per liter, that and is very important. You have to have both of these. If you meet both of these, then you get a diagnosis of septic shock. So kind of going back and recapping, you have to have a suspected infection first, as always with sepsis. At that point, you should calculate a Q-SOFA score. If you have a Q-SOFA score of 2, then you go on to your SOFA score. If you have a SOFA score of at least 2, you're considered sepsis. Once you're considered sepsis, if you have vasopressors on and you have a lactate greater than 2, then you can be considered septic shock. So it's very important to memorize the sequence of events in this figure, as well as knowing what your Q-SOFA variables are, as well as being able to calculate a Q-SOFA score. If it's asked on an exam, we will give you the SOFA score automatically. I will not expect you to calculate a SOFA score on an exam. So now that we talked about what sepsis is, giving you a definition of sepsis as well as septic shock, now let's move on to the treatment. So in terms of treating sepsis, it's important that you obtain cultures first if possible to try to identify what kind of infection that you're dealing with. It's important to promptly administer empiric antimicrobials based off of potential infectious sources. If you know what the source is, to control it if possible. So say if you have a urinary tract infection, you may want to try to remove a urinary catheter if one exists, because that may be the potential source of the infection. And also, it's important to treat the most likely pathogens related to the possible sources that you have. If you have a patient who is hypotensive or has a lactate of at least 4, those patients should get fluid resuscitation. If they are refractory to fluid resuscitation, then you administer vasopressors. And then if they are still refractory to fluids as well as vasopressors, then you may administer corticosteroids. And if myocardial dysfunction exists, or a patient has what's called a cardiogenic component, or potentially a low cardiac output or cardiac index, or a low SCVO2, which is a measure of oxygen supply and demand, you may need an inotrope. You also have to provide other supportive care to these patients, as a lot of these patients may have some downstream effects from the sepsis as well, or may have some kind of organ dysfunction that needs to be treated. So we'll talk a little bit about that as well. So this essentially is kind of a summary slide of the things that we're going to talk about throughout the rest of this presentation. To start out with, in terms of the treatment, we're going to actually take a look back at the 2012 Surviving Sepsis Guidelines. And what these Surviving Sepsis Guidelines had in 2012 were what were called bundles. These bundles consist of a 3-hour bundle and a 6-hour bundle. So these are essentially things that you had to do in order to adequately treat your patient. Now, in the 2016 guidelines, they don't specifically mention these bundles anymore. However, you're still going to have to do a lot of the things that are in these bundles in order to adequately treat your patient still, even in the 2016 guidelines. So the first thing that you should do is measure a lactate level. Or one of the first things that you should do is measure a lactate level. And this can be obtained from the blood. Around the same time, you want to make sure that you obtain blood cultures prior to the administration of antibiotics. If you give antibiotics before you get a blood culture, you may actually potentiate eradicating the bug or the pathogen before you actually know what it is. Because if you treat it with antibiotics or antimicrobials at that point, it may be that your blood cultures are actually clear. Then you want to administer broad spectrum antibiotics. And those actually have to be within 1 hour of when sepsis is identified. So despite the fact that it's in the 3-hour bundle, this has to be within 1 hour. And then if you have a hypotensive patient or a patient with a lactate greater than 4 millimoles per liter, then you administer 30 mils per kilo of crystalloid. Moving on, there was also a 6-hour bundle in the 2012 Surviving Sepsis Guidelines. If your patient was refractory to fluid resuscitation, at that point, you could apply vasopressors to maintain a mean arterial pressure greater than 65. Step 6 was in the event that you had persistent hypotension despite volume resuscitation. So if you had septic shock or an initial lactate greater than or equal to 4, they would require you to measure what's called a central venous pressure and a central venous oxygen saturation. That central venous pressure was essentially a marker of volume status in the patient. Though even in the 2012 guidelines, they mentioned that this marker wasn't that great in terms of adequately monitoring volume status. It's still used. And the central venous oxygen saturation is essentially a measurement of oxygen supply and oxygen demand. So if you think about oxygen going throughout the body, whenever oxygen hits the lungs essentially, and then goes from the lungs eventually into the arterial circulation, you have an oxygen saturation of about 100% ideally. Once your oxygen gets taken away by your different cells in the body, that oxygen level actually decreases. And whenever eventually it gets back to your venous circulation, what we want is some utilization of that oxygen, but we don't want it to be overdone. So that actually comes out to having a venous oxygen saturation essentially of at least 70%. If you have an oxygen saturation less than that, we'll talk about what you do at that point. And then step 7 was to remeasure lactate if your initial lactate was elevated. And this is done about every 1 to 2 hours after your initial lactate was done. And ideally what you want to see is about a 10 to 20% decrease every 2 hours or so. And that indicates that your patient's oxygen supply and oxygen demand is actually getting better. So as I mentioned before, with the 2016 guidelines, it eliminated the 3 and the 6 hour bundles that were used in the 2012 guidelines that we just mentioned. But though those bundles were eliminated, almost all the components of the bundle still have to be done per the 2016 guidelines, with the exception of step 6, which was that CVP, or central venous pressure, as well as central venous oxygen saturation. What the 2016 guidelines actually focused on is looking at multiple parameters to assess patients' fluid responsiveness. So CVP and SCVO2 were a couple things you could potentially look at to assess volume status and oxygen supply and oxygen demand, which fluids can potentially help with. But some other things you want to look at too are blood pressure, making sure that your patient actually is becoming more normal tensive. Urine output, seeing that your patient's urine output is actually increasing if your patient had an acute kidney injury in the first place. Again, CVP and SCVO2, lactate clearance, which we just talked about briefly with the lactate decreasing about 10 to 20% every 1 to 2 hours. You also may assess patients by passive leg raising. What this means is raising the leg to essentially move fluid around to see if it can actually raise your blood pressure. If you move the leg up and your blood pressure goes up, that means that the patient can be potentially fluid responsive, and you may want to give fluids to those patients. And there are many different other parameters that they look at in the guidelines as well. But they kind of wanted to get away from just looking at CVP and SCVO2 as parameters for fluid responsiveness. So they want you to look at the entire picture of the patient. So as I said before, these are your 3-hour bundle. And the first thing that we're going to focus on in the 3-hour bundle is to obtain blood cultures prior to the administration of antibiotics, as well as administer broad-spectrum antibiotics or antimicrobials within the first hour. In terms of the 2016 guidelines, what they say, and this is a quote from the guidelines, is that they recommend that appropriate routine microbiological cultures, including blood, be obtained before starting antimicrobial therapy in patients with suspected sepsis or septic shock if doing so results in no substantial delay in starting antimicrobials. and BPS essentially stands for best practice statement. So they didn't necessarily have a level of evidence or a strong, moderate, or weak recommendation label on this particular statement. But essentially what this statement means is that you should get cultures before you start antibiotics. With the exception that if you're having to wait, 45 minutes to an hour to even longer to try to get cultures on a patient, at that point, the risk outweighs the benefit. And at that point, and that point only, you should start antibiotics. You need to start antibiotics as quickly as possible. But when appropriate cultures can be done on a patient, they have to be done first. The next recommendation from the 2012 bundles that still appears in the 2016 guidelines is about antibiotic or antimicrobial timing. And what they say is we recommend that administration of IV antimicrobials be initiated as soon as possible after recognition and within 1 hour for both sepsis and septic shock. And that's a strong recommendation with moderate quality of evidence. So once that time clock starts ticking, once you have a diagnosis of sepsis, you need to get your patient antibiotics as quickly as possible. Ideally with blood cultures drawn first, as well as other cultures that may pertain to whatever source that you have. This statement is actually supported by this study here, which actually showed that whenever you had patients who had delayed antimicrobial therapy and were in septic shock, you actually had an 8% decrease in survival for every hour that antimicrobials or antibiotics were delayed. And that's pretty big. So the big point here is that if you give patients antibiotics earlier, you increase their chance of living. If you wait, or if you misdiagnose and your patient actually has sepsis and you said that they didn't have sepsis, what that can actually result in is patients with delayed therapy. And by the time that you realize they have sepsis, or by the time that you give them antimicrobials, they may already have a small or minimized chance of actually surviving that sepsis insult. So, in terms of choosing antimicrobials in sepsis, it's important to think of what the patient's infection site is, what the most likely pathogens are, if the infection is community versus hospital acquired, if the patient has a good or a bad immune status, or is immunocompromised essentially, have they had any recent antibiotic exposure within the last 3 months, as well as antimicrobial susceptibility and resistance profiles per the institution where you're at. So depending on all these different factors, that will guide what agent you pick. It's also important to optimize your dosing strategies based on pharmacokinetics and pharmacodynamics. And the sepsis guidelines actually have recommendations for that if you see Part D Recommendation 5 from the 2016 guidelines. I won't expect you to know doses for these medications, but it's important to realize that there are recommendations for doses based on pharmacokinetics and pharmacodynamics in septic patients, which can be very complicated. Essentially, what the important thing to realize here is that you should dose as high as possible without causing much risk. So say, for example, your patient has decent renal function, you should dose as high as possible that's allowed for that patient's renal function if the antibiotic is renally eliminated, for example. So you want to optimize your dosing strategies on those antimicrobials. And then also consider de-escalation after a few days in response to clinical improvement and or evidence of infection resolution. So say, for example, if you have a patient who has a culture that's positive to specific organisms and you have specific susceptibilities to specific antibiotics, you may de-escalate a broad antibiotic to a more narrow antibiotic. So for example, for a patient who has an E. coli and you have them on meropenem and the cultures come back and it's susceptible to something like ceftriaxone, potentially changing that meropenem to ceftriaxone, if that's your only infection, may be an appropriate recommendation. If your patient is culture negative and also has clinical improvement, that may be an indication to either de-escalate antibiotics or to potentially discontinue antibiotics. But you also have to keep in mind whether or not there's actually an infection there. If there's actually an infection there, you need to follow adequate timing and duration recommendations for those patients. The one thing to note with septic patients is that about a third of septic patients actually are culture negative, even though they may actually have a true underlying infection there. Another thing, obviously, you want to look at is clinical improvement. Is your patient getting better on the current therapy that they're on? And there's no necessarily best way to determine whether or not to de-escalate a patient, but you should look at all these different factors to determine whether or not to de-escalate a patient or not. Now, in terms of de-escalation after a few days, some people will say to try to de-escalate the patient after at least 3 days if you see no evidence of infection and you see clinical improvement. Some people may say potentially a little longer than that. It's really debatable, but you should use your best clinical judgment to make those calls. So there are many different potential sources of sepsis and septic shock that are out there. So remember, sepsis has an underlying infection component. So things such as skin soft tissue infections, urinary tract infections, pneumonia, respiratory tract infections, intra-abdominal infections, bacteremias or line infections, fungal infections, viral infections, or potentially others can cause sepsis. We're going to focus mainly on these first 7 here, as they're probably some of the more common causes of sepsis. But just keep in mind that almost any infection, depending on your patient's immune status as well as how bad the infection is, can cause sepsis. The first one we'll talk about is skin and soft tissue infections. So some things that you should know in terms of the diagnosis of skin and soft tissue infections is, if possible, you should obtain a gram staining culture for any obvious wound exudates that come up from whatever wound that you're looking at, and to potentially obtain a needle aspiration of a closed infection like a cellulitis or an abscess for a gram stain as well as culturing. In terms of the treatment of skin and soft tissue infections, you should clean the infection first if possible. So remember, you should always do source control first. In terms of patients who have what we consider community-acquired skin and soft tissue infections, a lot of times those infections will either be gram-positive related or MRSA related. And there are some exceptions to this, such as, for example, diabetic foot infections. But just in general, if you don't know necessarily what it is, and it's just a standard community-acquired skin soft tissue infection, you should use something that covers MRSA, such as vancomycin, linezolid, or daptomycin. If the skin soft tissue infection is what's considered hospital-acquired, then pretty much all bets are off at that point, and it can be almost anything: gram-positive, MRSA, gram-negative, Pseudomonas, or anaerobic. So in those cases, you want a gram-positive agent like vanc, linezolid, or daptomycin, plus a gram-negative anti-anaerobic agent, i.e. piperacillin, tazobactam, or zosyn. For urinary tract infection diagnosis, some common symptoms you may see are dysuria, hematuria, change in frequency, urgency, lower abdominal pain, and flank pain. For these patients, the first thing that's typically done whenever these symptoms are seen is to obtain a urinalysis. And whenever you're looking at the urinalysis, you should look for nitrites, leukocyte esterase, white blood cells, bacteria, or cloudy urine. Any combination of these things can indicate a potential urinary tract infection. It's also important after that urinalysis, if you're still having some kind of suspicion of urinary tract infection, to obtain a urine culture. For urinary tract infection treatments, it's important to remove any pre-existing urinary catheters if possible first, so always do source control first. For community-acquired urinary tract infections, we're typically thinking gram-negative organisms. So as a result, a third-generation cephalosporin actually covers most of the gram-negatives that we're concerned about, such as ceftriaxone. For community-acquired, we're not really concerned about Pseudomonas, and we're not really concerned a lot about Pseudomonas with the hospital-acquired either. Now, for community-acquired, you can also do ciprofloxacin or levofloxacin, but you have to be careful because of the nature of the infection, you may actually have increased resistance to these agents in the urinary tract. So ceftriaxone may be a little bit more reliable, though you aren't necessarily wrong if you choose ciprofloxacin or levofloxacin. It just depends on where you're at in your institution and your resistance rates. If you have a hospital-acquired urinary tract infection treatment, the treatment of those is not a lot different than the community-acquired, so think gram-negative again. The only addition that they have here is ceftazidime compared to the community-acquired. And remember, ceftazidime is also a third-generation cephalosporin. And this cephalosporin can actually cover against Pseudomonas, though that, again, is not our main bug that we're trying to think of in terms of hospital-acquired urinary tract infections. For respiratory tract infection diagnosis, some symptoms you may see are shortness of breath, fever, cough, and sputum production. For these patients, it's always important to obtain chest imaging to identify any possible infiltrates, especially if you're considering a patient having pneumonia. If you can obtain respiratory secretions if possible for culture, some patients may produce these, some patients might not. So if you have them available to you, you should use them. And you can also obtain a urinary antigen for Legionella to detect Legionella during outbreaks, which, remember, Legionella is one of those popular atypicals that you may see appear in a community-acquired pneumonia. So with respiratory tract infection treatment, for community-acquired infections or CAP, you want to think about Streptococcus, H. flu, and atypical coverage. And this can be done with either Levaquin or levofloxacin, moxifloxacin, or a combination of ceftriaxone plus azithromycin. So remember, you always have to have your atypical coverage with community-acquired pneumonia. Now, with hospital-acquired pneumonia, that atypical coverage isn't necessary because you won't see atypical bugs as much with hospital-acquired pneumonia. With hospital-acquired pneumonia, it's pretty much anything goes. So you have to think gram-positive MRSA, gram-negative Pseudomonas, and then you may or may not have anaerobes associated with this. Some situations where you may actually have an anaerobic bug associated is if you aspirate. Because remember, if you aspirate, you're aspirating contents of your stomach up. And as a result, your stomach has a lot of anaerobic bugs. Whenever you have anaerobic bugs, those anaerobic bugs can cause infections. So it may be important for patients like that to have gram-negative coverage for potential gram-negative organisms in the abdomen, as well as anaerobic coverage for anaerobic organisms in the abdomen that may aspirate. So for hospital-acquired infections, so this essentially includes hospital-acquired pneumonia or HAP, as well as VAP, or ventilator-associated pneumonia. You should have a gram-positive agent like Vanc, and a gram-negative agent with or without anaerobic coverage, so Zosyn, ceftazidime, cefepime, Levaquin, Cipro, an aminoglycoside, or a carbapenem that is not ertapenem. Because remember, ertapenem does not cover against Pseudomonas, and that's one of the things that we want to cover in a lot of the hospital-acquired infections, particularly pneumonia. For patients with intra-abdominal infections, we're concerned about abdominal pain, nausea, vomiting, constipation, diarrhea, abdominal distension, abdominal tenderness, and bloating. A CT scan can be done to identify fluid collections in these patients, and if you can, it's important to aspirate fluid collections to gram standing culture if possible. Sometimes these will actually be done in the process of a thoracentesis or a paracentesis. For treatment, you always want to do source control first, so drain any abscesses or fluid collections first, and you may need surgical intervention. For community-acquired intra-abdominal infections, we're thinking gram-negative infections as well as anaerobic infections, not necessarily Pseudomonas at this point, because remember, Pseudomonas is mainly a hospital-acquired bug. So as a result, you can use ertapenem for these community-acquired intra-abdominal infections, or a combination of metronidazole, i.e. flagyl, with a fluoroquinolone like ciprofloxacin or levofloxacin. For hospital-acquired infections, you think gram-negative, you think Pseudomonas, and you think anaerobic. So with hospital-acquired, think Pseudomonas for intra-abdominal infection. So as a result, you can use Zosyn or piperacillin tazobactam because it'll cover gram-negative Pseudomonas and anaerobic. And you can use a carbapenem that, again, is not ertapenem because ertapenem will not cover against Pseudomonas. In terms of bacteremia, bacteremia essentially is blood that has some kind of microbial pathogen or bacteria. Bacteremia is commonly associated with a line infection or a catheter-related infection. And it may also result from other infections migrating from their original source. So you may have a urinary tract infection that eventually develops into a bacteremia, depending on how deep down the line that urinary tract infection is. Whenever you're concerned about bacteremia, and in any sepsis presentation in general, you should always get blood cultures. And you should typically get these blood cultures from 2 different sites with anaerobic and aerobic bottles. In terms of bacteremia treatment, if the bacteremia is just a catheter-related bacteremia suspected, at that point you want to think gram-positive or MRSA, because whenever you shove a catheter up someone's skin into a vein, you're essentially shoving staph or strep potentially from the patient's skin into that vein. As a result, vancomycin will cover a majority of those cases. Now, if you have a bacteremia that's a result of something else that's not catheter-related, you would have to think about the original source where that bacteremia came from, and you need to cover that instead. Antifungal therapy. So antifungal therapy is something that's not traditionally put on empirically upfront in most patients, but you should consider antifungal therapy for sepsis or septic shock if you see any of the following. The biggest one that we see in practice is immunocompromised patients. So anybody that has neutropenia, so ideally like a white count less than 4 potentially. Anybody who's on chemotherapy, who is immunosuppressed via the chemotherapy, or transplant patients who are immunosuppressed via the immunosuppressive agents that they're on. And some examples of those are like tacrolimus, mycophenolate, cyclosporin, steroids such as prednisone, etc. These patients are at higher risk of developing fungal infections. And if you see patients with an immunocompromised state, you should potentially put on an antifungal agent first, along with the other broad spectrum agents, depending on what the source of infection is. TPN is another big source of potential fungal issues and that is related to the fat emulsion component of the TPN, which we'll talk about a little bit whenever we talk about nutrition support later this semester. Anybody who has prolonged invasive catheter or vascular devices, recent major surgeries, prolonged administration of broad-spectrum antibiotics, prolonged hospital ICU admission, anybody that has a recent fungal infection or previous fungal antimicrobials such as azoles or echinocandins that have been won before, for example. And then multi-site colonization. So if you have patients who have multiple infections or multiple sites of infections, that's something to be concerned about. For antifungal treatment, if you have a patient who you want to start on antifungal treatment, for hemodynamically stable patients who have decent blood pressures, triazoles are acceptable, such as fluconazole. For patients who have septic shock or severe illness, echinocandins are preferred due to their broader coverage. And these are agents such as caspofungin, micafungin, and anadulafungin. For patients who have echinocandin tolerance or toxicity, which, to be honest, you won't see a lot in practice because echinocandins are relatively benign in terms of their side effects. However, if you do see that, for one reason or another, you can potentially use liposomal amphotericin B on those patients. For patients who you suspect of having some kind of viral issue, the most common viral issue that we see here is the flu, especially considering that we're still in flu season. For these patients that you suspect of having the flu, it's important to obtain some kind of viral culture or reverse transcriptase polymerase chain reaction, or RT-PCR, if possible. And Dr. F probably talked about this a little bit in his flu talk. If you suspect any viral source empirically, or if you have a positive result from a flu test, then you can treat patients with a neuraminidase inhibitor, such as oseltamivir, zanamivir, or peramivir, with oseltamivir being the most common one that you'll see in practice. If you have an unknown source for infection, so if you have no idea what the source is and your patient's coming in and you're completely blind, you pretty much want to cover your big players, so gram-positive, MRSA, gram-negative, Pseudomonas, and anaerobic coverage. Again, you won't necessarily typically cover antifungal or antiviral first unless your patient actually has risk factors for those. So in those cases, you should start the patient on those therapies if you suspect that. But in general, gram-positive agent like vancomycin, as well as a gram-negative agent with or without anaerobic coverage should work. So those are zosyn, ceftazidime, cefepime, carbapenem. That's not ertapenem, because again, ertapenem does not cover Pseudomonas. In terms of the duration of antimicrobial therapy in the 2016 guidelines, they suggest that an antimicrobial duration of 7 to 10 days is adequate for most serious infections that are associated with sepsis and septic shock, even though it's not a great recommendation because they don't have a lot of evidence behind that. They do say that shorter courses may be appropriate for patients who have what's called rapid clinical resolution following source control of intra-abdominal or urinary sepsis, and those with anatomically uncomplicated pyelonephritis. So in those cases where you have patients who have a urinary sepsis or an intra-abdominal sepsis, for example, you may get away with a shorter course than 7 days, i.e. like 5 days. Even for urinary tract infections, you can potentially go as low as 3 days, depending on how severe you think it is. Longer courses may be appropriate with some infections, or for patients who have slow clinical response to antibiotics or to source control. If you're not able to drain the actual foci or the source of the infection, patients who have bacteremia with Staph aureus, which a lot of times with those patients with bacteremia, you'll actually treat probably closer to 2 weeks. Some fungal and viral infections, and then patients who have any kind of immunosuppression or immunological deficiencies like neutropenia that we talked about earlier. So going back to our bundle, our 3R bundle, we talked about steps 1, 2, and 3. So lactate level, blood cultures, and other appropriate cultures, as well as administering broad spectrum antibiotics, antimicrobials. The next thing that you should do in this 3-hour bundle is administer 30 mL per kilo of crystalloid fluid for patients who have hypotension or lactate greater than 4. Per the 2016 guidelines, they recommend that in the resuscitation of sepsis-induced hypoperfusion, at least 30 mL per kilo of IV crystalloid fluid be given within the first 3 hours. So after you diagnose sepsis, you need to get on board and give them that 30 mL per kilo of IV crystalloid. So what is sepsis-induced hypoperfusion? So that, or sepsis-induced hypotension, that is going to be a MAP of less than 65 or systolic blood pressure of less than 90. So if you have either of those, you automatically qualify for the 30 mL per kilo of IV crystalloid. If you have hypoperfusion with a lactate greater than 4, you also qualify. So either one of those, so this one or this one, will work for the 30 mL per kilo. Now, in this case, when giving crystalloids, you should use isotonic crystalloid fluids, such as normal saline or lactated ringers. Reason being is that other fluids, such as dextrose 5% and water, for example, while it is a crystalloid fluid, it is not an isotonic fluid. Therefore, a lot of the fluid that you're actually giving the patient is going into your intravascular spaces, which is not really helping your vascular spaces, which you need to essentially support in sepsis. More of your fluid from the normal saline as well as the lactated ringers is staying in the vasculature, and that's why you give isotonic fluids first. Now, after you have that 30 mL per kilo of IV crystalloid, if you're still not doing so hot and you're still hypotensive at that point, you can use albumin in addition to crystalloids if they require a substantial amount of crystalloids. And hydroxyethyl starches are not recommended, though not a lot of people will actually use those anymore. But that's just an FYI. If you ever hear about recommendations for hydroxyethyl starches, they are not recommended. Now, this diagram is very important to know. The biggest thing that you should realize from this is that no matter what kind of factors that you have, as long as you have a sepsis-induced hypotension that we just discussed, or a lactate greater than 4, you qualify for 30 mL per kilo of crystalloid fluid. So no matter if you have ESRD, CHF, pneumonia, acute lung injury, all of those qualify for 30 mL per kilo, even if you may consider the patient to be volume overloaded. It's still important to support your patient's intravascular status. So there's actually more benefit in giving them fluid than not giving them fluid. And there's another one too. This must be done within 3 hours. Now, in terms of the second part of the bundles, or the 6-hour bundle from the 2012 Surviving Sepsis Guidelines, the next step is to apply vasopressors for patients who aren't responsive to initial fluid resuscitation to maintain a MAP of at least 65. So you've given your patient crystalloids. It didn't work. Your patient's still tanking and hypotensive. What do? So at that point, you can actually start vasopressor agents. So the first agent that they recommend in the sepsis guidelines is norepinephrine. Norepinephrine has a lot of alpha activity, which will clamp down on your vasculature to increase your MAP. It also has a little bit of beta effect, which will actually cause your heart to contract a little more and may increase your cardiac output and cardiac index. And in terms of septic patients, these patients are already what we call hyperdynamic, and they may already have increased cardiac outputs to start with. Now, if you titrate up your norepinephrine and you realize that your patient's still tanking and has a MAP less than 65, at that point you can add vasopressin as your second-line vasopressin on top of norepinephrine. Now, the benefit of vasopressin in sepsis is that vasopressin can actually be depleted in patients with severe shock whenever patients are in prolonged shock. So we have vasopressin stores in our body. If your patients have been in shock for an unknown period of time or for very long, giving them vasopressin can actually replete those stores and help clamp down on that vasculature to provide blood pressure support. Now, once you have already exhausted your norepinephrine and vasopressin, that's when you need to start asking questions. Is your patient's shock still vasodilatory and related to sepsis? Is it cardiogenic and potentially related to some kind of decreased cardiac output or cardiac index or impaired oxygen supply and demand? Or is it due to something else? Now, if your answer to that is vasodilatory, the next thing that's recommended is epinephrine. Epinephrine acts by acting mainly on beta receptors, but it also has a lot of alpha activity. So it can help clamp down on your vasculature, but give you a little bit of support for your heart too. Now, if these three potentially don't work, or say if you have a patient who has some kind of tachyarrhythmia on norepinephrine or epinephrine because these agents work on beta receptors and can potentially stem arrhythmias because they act on beta receptors on the heart, then you can potentially switch either of those agents or both of those agents to phenylephrine, which has none of the beta effect. And dopamine is typically recommended last line as a vasopressor in sepsis. And the reason why is actually because of this comparison that was done here in the 2012 guidelines. If you look at the mortality differences, adverse effect differences of supraventricular arrhythmias, as well as serious adverse effects in terms of ventricular arrhythmias, you see actually higher incidence of morbidity and mortality with dopamine than you see with the first-line agent norepinephrine. So there actually is potentially more harm in giving dopamine to a septic patient than giving norepinephrine. That's why dopamine is the last line here. So dopamine only in special cases only. If your patient needs inotropic support or support for increasing your patient's cardiac output or cardiac index or has some kind of oxygen demand problem, you need to give them inotropic support. And you should be evaluating this throughout their potential stay. A lot of times it should be done after your patient's already on a couple of vasopressor agents. What they suggest in the guidelines is using dobutamine in patients who show evidence of persistent hyperperfusion despite fluids as well as vasopressors. So in practice, typically, should be done after at least 2 vasopressors are being currently administered, and there's evidence that the shock has some cardiogenic component, i.e. a low cardiac output, a low cardiac index, or a low SCVO2. So if you have numbers below any of these ranges, you should be concerned that your shock has some kind of cardiogenic component. For patients who are in sepsis, you would expect these numbers to either be normal or to be elevated because your body and your heart is trying to compensate for the lack of perfusion that the rest of the body is getting. So your output is actually a lot higher typically in sepsis. But in the event that it's not, you should start an inotropic agent like dobutamine. And these values here will be very important for you to know, so that's why they are bolded. You must know the ranges for the normal range of these values. For patients who are still refractory to fluid and vasopressors, you may actually give these patients with IV hydrocortisone or a corticosteroid to achieve hemodynamic stability. And what they suggest in the guidelines is 200 milligrams per day or 50 milligrams IV every 6 hours. And it's a weak recommendation with a low quality of evidence because it's been shown in some studies not to have any mortality benefit. But in some patients may actually need the steroid as a little bit of a kick. And essentially what the steroid is doing is it's acting as an anti-inflammatory, or what it's thought to act as an anti-inflammatory agent to kind of compound or fight against the inflammatory process that sepsis is. So this is typically done after at least 2 vasopressors are currently being administered. So ideally after norepinephrine and vasopressin have been on and you're still taking, you should start a corticosteroid on those patients. This is essentially a good chart of what to do for patients who are hemodynamically unstable and have already gotten adequate fluid resuscitation. So at this point, you would start norepinephrine. If your target is achieved at that point, you can potentially continue norepinephrine alone, or you can even add vasopressin, because vasopressin can potentially decrease the amount of norepinephrine that you may need. If your MAP target is not achieved after you've maxed out your your norepinephrine dose, then you can add vasopressin. If it's not achieved at that point, then at that point, what these little stars mean is that you should consider IV steroid administration or actually do IV administration. So essentially, that should be probably done somewhere between the vasopressin step and the next step of epinephrine drip. So if you have a patient who's still taking on norepinephrine and vasopressin together, it's a very, very high suspicion that you're going to need steroids. If you have put on epinephrine as well as vasopressin, norepinephrine, and steroids at that point, your MAPS target is still not achieved, then you can consider other last-line agents like phenylephrine or even possibly dopamine. Though phenylephrine is not technically mentioned in the guidelines. There are some other supportive care things that you may need to do for patients who are in sepsis. You may need to give them blood products because their hemoglobins may be low. As a result of that acidosis that we talked about earlier, they may generate a respiratory alkalosis and may need to be put on the ventilator. You may also need sedation and analgesia while the patient is on the ventilator. Because of inflammatory response, you may have patients who have high glucose levels and they may need glucose control with either sliding scale insulin or an insulin drip, some kind of protocolized insulin protocol. They may need renal replacement therapy as a result of any acute kidney injury or chronic kidney injury or disease that they have. These patients may also need DVT or stress ulcer prophylaxis, as well as nutrition support. Now, a lot of these things you'll actually discuss in other classes potentially, but the main focus of what we're doing in this class is focusing on how to initially treat them and stabilize them. This other stuff may come a little bit later, potentially after the initial management, except for potentially mechanical ventilation, because sometimes that actually happens very quickly. Here are the references for today's talk. Let's go over the case questions. So we had AF, our male, who was presenting with ultramental status, dysuria, hematuria, fever, hypotension, and low blood pressure. He had a QSOFA of 2 and a SOFA score of 2. Hadn't received any treatment late, and the lactate is pending. Which of the following is his most appropriate diagnosis? So the answer here is sepsis. The reason that the answer is sepsis is because, as we mentioned, he has a suspected infection, potentially a UTI, because he has symptoms matching what a UTI would be, such as dysuria and hematuria. It'd be ideal for him to get a UA, though we don't have it provided here. He also has a current fever of 102, which may signal an infection as well. So that's one of our SIRS criteria, though he doesn't necessarily meet 2 SIRS criteria that we would need from the 2012 definitions. But from the 2016 definition, because he has a QSOFA of 2 and a SOFA score of 2, he meets sepsis. Remember, we eliminated severe sepsis as a definition in 2016. And then in terms of septic shock, because he's not on any treatment yet and is not on vasopressors and we don't have a lactate, we can't consider him to be in septic shock, though he may very well eventually progress to that point. You have to have some kind of vasopressor treatment to be considered septic shock now with the 2016 definitions. To treat AF's underlying infection, the ED physician would like to start an antibiotic, which antibiotic should be initiated to treat AF. So the first thing you have to think about in terms of this question is what kind of infection does AF have? And based off of the symptoms that we noted, he potentially has a urinary tract infection. So if you go back to what antibiotics treat urinary tract infections, you're thinking ideally gram-negative that does not require pseudomonal coverage. So the answer to this question would be ceftriaxone. Gentamicin and meropenem are a little bit overkill as they provide pseudomonal coverage as well as broad-spectrum gram-negative coverage, which we may not necessarily need all of that coverage, particularly the pseudomonas component. Vancomycin will cover gram-positive organisms and may not be ideal empirically for a UTI, as about 80% of UTIs are caused by gram-negative bugs. Case question 3. So, to attempt correction of this hemodynamic instability, the ED physician would like to start fluid resuscitation. Which IV fluid should be started to resuscitate AF? The answer here is normal saline. The reason it's normal saline is because normal saline is an isotonic crystalloid fluid. Albumin may be started after you do an isotonic crystalloid fluid, assuming that you've done probably about 30 mils per kilo of your isotonic fluid. D5W is not ideal because D5W is hypotonic and won't get into the vasculature as much, and hydroxyethyl starches are not recommended for fluid resuscitation in septic patients. If you have any questions, feel free to let me know. You can email me at my email address here, and I'd be happy to answer any questions you have. Thanks, and have a good day.